Okay.
You kind of
Uh, so we have several questions regarding hypothyroidism, and most of you have already resolved. One
yes.
question regarding reversibility. One of your slide, you have shown almost 50% chances of reversibility without any treatment. So, is there any medication or change in the diet pattern, particularly gluten-free diet, to enhance the reversibility of hypothyroidism, particularly autoimmune hypothyroidism?
No, I don't think so. I mean, it's hard to explain why a person would have a TSH of 7 and then you check it again and it's normal 6 months later. Why would that even be? And it may be that they do have mild autoimmune thyroiditis that was, you know, came on and then it just sort of resolved. But I don't think there's anything we know of that's going to accelerate that process. I mean, some people believe that selenium, for example, may have beneficial effects in people with autoimmune disease, but I don't think there are data to show that, that's really something that we should be doing, but I can't say it would be bad. But I don't know of anything specifically that would do this. But it's an interesting phenomenon. I think it just teaches us that we should not just intervene with medication without checking the TSH again in a few months to be sure that it's still persistently elevated.
Okay, thank you, sir.
Sure.
Then another question is regarding thyroid dyslipidemia. In many patients of hypothyroidism, we frequently see higher LDL levels. So the question is, does it increase the cardiovascular adversity, and after treatment it goes off?
So obviously, none of you are probably old enough, and I am not old enough either, to remember that back in the 1920s and 30s and 40s, there were no thyroid function tests at all. And the way they evaluated thyroid function was to measure lipid levels, which were very, very high in people with hypothyroidism and very low in people with hyperthyroidism. So this is a known phenomenon that hypothyroidism is associated with dyslipidemia. And of course, in somebody with overt hypothyroidism, when they are put on medication, the lipid levels normalize. But that is not necessarily the case in subclinical hypothyroidism. And people have looked at this very carefully. Some studies suggest that maybe the lipid levels are slightly high and become more normal with treatment. Other studies have not really shown any difference in lipid levels or even lipid subfractions or other manifestations of atherosclerosis like carotid intimal thickness. There's really not a lot of data to show that in subclinical hypothyroidism that this is a problem. So it's true for overt hypothyroidism, but not necessarily for subclinical. But if you remember, I showed you a slide where there was less cardiovascular disease in people under the age of 70 who were treated with levothyroxine. And so you must think that maybe it's doing something for cardiovascular health. And that's why I do think that people who are younger than age 70, who have TSH levels, let's say that are in the 5 to 7 range, you could make a case for treating them. Yes.
Thank you so much, sir.
Okay.
Then there is a clinical scenario. There is a patient, almost 30-year-old female, and she is complaining of persistent fatigue. And on checking her thyroid function test, she has normal free T4 and TSH is 2.5. However, the TPO level is more than 1000, and there is mild goiter is there. So should we start treatment in that patient, or we should wait for some time and check with thyroid function test?
That's a really good question. We do know that when people have mildly elevated TSH levels, that can cause goiter. And when you treat the person and normalize their TSH, the goiter does decrease in size. Now you say, oh, the TSH in this patient's only 2.5, but I think it would be reasonable to try to treat the person and get their TSH down, let's say less than 1, between 0.5 and 1, and then maybe get an ultrasound in a year and see if because I didn't have a chance to even talk about this, but in addition to goiter, there's an increased risk of thyroid nodules and thyroid cancer in patients who have Hashimoto's thyroiditis. And it's linearly related to their TSH. So in people that have an abnormal thyroid on exam or on ultrasound, I think it's reasonable to treat them. especially if their TSH, let's say, is, between 2.5 and 4, I would definitely treat them. Now you say, well, it's only 2.5, but I still would probably treat that person to try to get their TSH a little lower, especially if it's a young person. Yeah. That's a good question.
So then there is one more question. Basically, we get frequent calls from our reproductive medicine consultants while going for ovulation induction and retrieval of ovum. Most of when the thyroid function test is checked, the TSH is usually in the subclinical range. So they ask us whether to retrieve ovum at that time or leave for at a better time when TSH is within normal limits.
So their TSH is on the high side, or they have subclinical. And what was the clinical scenario here? I didn't catch the beginning of your question.
So the clinical scenario is the patient, they are going for assisted reproductive therapy. And
Yes.
yes,
Okay. Yeah. Again, this is a real big controversy. And I think there's really not a lot of evidence that treating somebody with levothyroxine whose TSH is less than 4 alters the outcome of in vitro fertilization or reproductive assisted technology. But the people who do this, the reproductive endocrinologists, are really focused with like a laser beam on having the TSH less than 2.5. I do not know why this is. There's really not a lot of data to support this. But what the heck, right? Why not just treat the person, make the doctor happy? There's no reason not to treat the person. If they do get pregnant, they're going to have to be on a higher dose anyway. Most people have to have their dose increased anyway. So I'm happy to, and maybe it does help. I don't know. I mean, the studies have shown that it probably doesn't lead to increased levels of pregnancy or, live births. But gosh, I don't know. I think if the doctor really wants the TSH to be less than 2.5, I'm okay with that.
so then one more, this is the last question, sir. And actually this patient came to my OPD recently, and she was on levothyroxine therapy for almost 2 months, and she developed urticarial rash. And then when it was stopped, the rash disappeared. So when she came to my OPD, I just switched over to another brand, and the symptoms resolved, and she is presently good with that thing. So basically, is there any other modality by which we can take care of thyroxine hypersensitivity? Because I had searched in literature, there is a cumbersome method of desensitization. So can we go for some another option if there is no facility of desensitization?
I think the person who asked the question did the right thing. They just switched the person to a different brand and everything's okay now. So there probably are things in the pills to which some people react. There are different excipients and different brands and different products. The dye itself or some other inert ingredient may be triggering urticaria. But it's also important to remember that urticaria occurs in people that have autoimmune thyroid disease spontaneously. In other words, they have a higher frequency of urticaria, just spontaneous, from being allergic to other things too. So the treatment in that case, let's say a person has been on levothyroxine, the same dose, same product for 5 years, and now they have urticaria. You can't say it's the thyroxine. And those people do respond to antihistamines, usually. So in that case, the scenario, I might have switched them to a different product, but the other treatment might have been just to try an antihistamine also.
Thank you, sir, for those crisp, clear, and very informative talk covering a spectrum of hypothyroid individuals. Thank you very much.
You're welcome.
I have a lot of questions, but I'll take a few of them. The first question is in regards to TSH estimation timings. Does the timing of blood collection matter?
No. There is a circadian rhythm to TSH. It is higher in the evening. So after 11 o'clock at night, in other words, if you admit someone to a research center and draw their blood once every hour for 24 hours, there is a rhythm, but it's highest at night. So it really doesn't change much during the day. So the answer would be no, it really doesn't matter.
Prandial, non-prandial does not matter.
No.
Okay. So there's another question in regards to interpretation of reports that they come across reports with normal T3, T4 with raised TSH and vice versa in regards to its interpretation.
Well, if the T4 and T3 are normal and the TSH is elevated, that is subclinical hypothyroidism. Now, if the patient is 80 years old and the TSH is 6, that could just be a normal TSH for that person. You might repeat the tests in a few months to see if it's stable. Sometimes the TSH can be transiently elevated because of mild thyroiditis, let's say. But there's no, so there are a couple of other reasons why the TSH could be high. One is severe obesity can make the TSH high. This has to do with leptin, which is secreted by fat cells that acts on the hypothalamus and pituitary to increase TRH and TSH secretion. And this resolves as soon as the person loses weight. So there can be sort of a falsely elevated TSH in extreme obesity. But generally speaking, if the TSH is high, it means they have mild hypothyroidism, or it's just normal for that person if they're elderly.
And vice versa? The second part of the question was vice versa.
What was what?
The second part of the question was if T3, T4 is high and the TSH is low.
If the T4 and T3 are high and the TSH is low, then they're hyperthyroid. How about if the T4 and T3 are high and the TSH is high too? So what's that? So that is something that you should not ever see, right? So that could be a pituitary TSH secreting tumor, or it could be congenital thyroid hormone resistance, which does exist.
So I think this is an interesting question in regards to, since thyroxine has a half-life which is pretty long, can it be given once a week? Your thoughts on that?
Yeah, I mean, in certain circumstances where people are not able to take their medicine faithfully because of, let's say, cognitive difficulties or psychiatric problems, and they don't live in a facility where they can be given their medicine each and every day, a person, a relative, a family member could go and see them, or they could, just if they're living with a family member, they could be given their medicine 2 times a week, let's say, and that would be okay. I mean, it's not ideal, but it's better than not taking it at all. So yes, you could give a person all 7 tablets in 1 dose once a week. Yes, that could be done.
I had one question in regards to T3 dosing. One is in regards to its timing and in relation to its meal. Number 2, in T3 supplementation post thyroidectomy, total thyroidectomy, post malignancy, how do you dose it?
Well, as far as the absorption of T3 is concerned, we don't really know a lot about that. There haven't been a lot of studies on T3 absorption as opposed to T4 absorption. I think most people feel that it absorbed even better than T4 is. So it's probably better to, not take it with food, but it's probably okay to. So what I tell people patients is to take their first dose of T3 with their T4 in the morning, and then to take their second dose of T3 before dinner time. Remember, the half-life is a day for T3, so you have to take it twice a day. And then, what was your second? I can't remember the second part of your question.
In patients with malignancies post-surgery, when you're waiting radioactive iodine ablations.
Yeah. So most people who have had their thyroid ablated from surgery or Graves' disease with radioiodine, they feel perfectly fine on T4 monotherapy. I mean, I've had Graves' disease, I've had radioiodine, I've been on T4 therapy for 50 years. And I take T4, and I feel fine. But again, it's not everybody that needs or should be even considered for T3 therapy. It's just the occasional person who, after a thyroidectomy, let's say, they were feeling perfectly fine before they had their thyroid out. Now they're on levothyroxine. Their TSH is 1, but yet they're still tired. They're still gaining weight. They don't feel the same as they did before their thyroidectomy. That is the patient where you might consider T3 therapy.
My question was in regards to suppose a patient has papillary thyroid cancer and has undergone thyroidectomy. Now, while you're awaiting radioiodine ablation.
Yeah, I mean, so if you want to prepare the patient for radioiodine therapy, we do T3 for a few weeks while we're waiting for the T4 levels to decline, because its short half-life allows us to do that. I'm sorry, I didn't understand your question. But yeah, you could replace them with T3, let's say 10, 15 micrograms a day, something like that. In the United States, we don't usually withdraw people like that anymore. We use human recombinant TSH. So people stay on their levothyroxine and their TSH levels are high because of the exogenous TSH. I'm sorry.
Recombinant is pretty expensive over here. So it's almost a lakh rupee.
Yeah.
So that's the reason why, in case.
Sure.
I think, do we have more time for the Mumbai team or? Okay. So there's a clinical case that a patient with first trimester with a TSH of 3.1 and antibody is negative. Would you treat or not treat?
No. That's a normal person. Yeah.
I think we've covered most of the questions.
Well, thank you very much.
So one question was, is there a ceiling to the dose of levothyroxine? What is the maximum dose?
You know, it's funny. I got asked that yesterday too. And I don't know. I mean, in my, clinical career, I guess I've given people a high dose as 400 micrograms a day, something like that.
Okay, ma'am has a question that in severe hypothyroidism, first trimester, can the patient continue pregnancy if the TSH is more than 15?
Sure. So, yes, absolutely. I mean, the baby has its own thyroid after about 15 weeks of gestation. Now, the baby in the first trimester, some growth and development is dependent on the mother's thyroid hormone crossing the placenta. So you could argue that if the mother is severely hypothyroid, maybe the baby won't have enough thyroid hormone during the initial first trimester, but they can catch up. And I really don't think that having a high TSH like that would be a reason to terminate the pregnancy. I really don't. Because the baby ultimately will have its own thyroid.
Thank you very much. That's what it was from Mumbai team. Thank you, sir.
Thank you so much for your attention.
So greetings from Hyderabad.
Good evening.
Thank you, Dr. Cooper. It was an absolute pleasure listening to you.
Thank you.
Since we are the last to go, we don't have too many questions.
Okay, that's fine.
Start with one of the common questions, in fact. What would be your recommendation regarding the timing of thyroxine dose during periods of religious fast, like during the holy month of Ramadan?
It really doesn't matter when a person takes their medicine, since the half-life is so long. So if a person typically takes it in the morning, but then they're fasting and they can take something after sundown, let's say, they can just take it then. It doesn't matter that much. Just as long as they take their medicine every day. It really doesn't matter what time of day it is taken.
You had mentioned in your lecture about bedtime dosing of thyroxine. So
Yes.
what would be the recommendation regarding the time gap between dinner and the thyroxine dose?
Right. So patients always ask this as well. I mean, if they have dinner, let's say at 6 or 7 o'clock at night, and they go to sleep at 10 o'clock, there's this. And as I said, there have been studies looking at how long it takes for the stomach to empty after you have a meal. And a typical patient or typical human being, the stomach is emptied after about 2 hours. So as long as there's a 2-hour gap between the last meal and bedtime, that should be okay. And a lot of people, I'm sure you have patients like this too, where people sometimes set their alarm for 5 o'clock in the morning just so they can take their medicine, and then they go back to sleep even, so they don't have to interrupt their breakfast or whatever. And I just think that's really not, it's a little crazy. And so for those kinds of people, I think it's fine to take it at bedtime.
About 2 hours after dinner is what you would recommend.
Yes.
You also mentioned about seasonal variation in TSH levels. So would you recommend a change in dosing of levothyroxine during winter?
I didn't really mention that. That was on my slide. So there are studies from Japan mainly just looking at seasonal variability in TSH levels. And it's interesting that in the wintertime, TSH levels are higher than they are in the summertime. You might even think that maybe the body is trying to generate more thyroid hormone to make people warmer in the winter and maybe cooler in the summer. But that's not a factor that would go into changing the dose of medication or treating a person or anything. It's just kind of an interesting physiological fact.
So when would you recommend getting an anti-TPO antibody done other than subclinical hypothyroidism?
Never. I mean, if the person's hypothyroid, it doesn't really matter if they have antibodies or not. But if they're subclinically hypothyroid and they have positive antibodies, that might make you think, oh, maybe this is patients more likely to progress to overt hypothyroidism. That might be a reason to consider treatment. But if the person already is hypothyroid, let's say with a TSH, that's high and their T4 is low, it's almost always, it's Hashimoto's. There's no other diagnosis, assuming they haven't had a thyroidectomy or something. If it's spontaneous, then it's always Hashimoto's.
Your thoughts on role of selenium in thyroid disorders? Would you recommend selenium supplementation in any of the thyroid disorders?
That is a great question. And I don't have a great answer. So as many of you know, selenium has been used in various autoimmune diseases. Why it seems to be effective in some cases, I don't know. The problem is, at least for me, is that most of the studies that have shown that selenium may benefit people with autoimmune disease in terms of lowering their antibodies, or people with thyroid eye disease, where there's some evidence that it may help thyroid eye disease and Graves' disease. The problem is, in the United States, we don't have selenium deficiency. And most of the studies that have been done have come from Europe, where there is selenium deficiency in the general population in the diet. So that might be the reason why it works in some parts of the world and maybe not so much in other parts of the world. And I don't know what selenium intake is in India, for example. I bet this has been studied. There are people that, study this. So it might be interesting, but it's pretty harmless. So if a person wants to try taking selenium to see if that has an effect on, let's say, their antibody titers, that would be fine. I don't think, let's say a person has hypothyroidism and their TPO antibodies are 100. And now they take selenium and now their TPO antibodies are 50. I don't think that's really had any impact on their underlying thyroid problem, really, in terms of whether they need to be on medicine or not. There aren't any data to show that people can go from needing levothyroxine to not needing it just because they took selenium.
One last question. Is there any data to show any effect of hypothyroidism on cognitive behavior and memory in young patients?
I don't know of any, but I can't imagine that there would not be. I mean, any effect that it would have on older people, I can't imagine why it wouldn't have an effect on younger people too. But I don't know, I'm not a pediatric endocrinologist. I don't know the data on this. I will say that, at least in my experience, many pediatricians, when they find mild hypothyroidism in a child or teenager, they don't treat it. They think, oh, this is just going to go away as the person gets older. I don't understand that rationale. If a person, let's say a 12-year-old, has a TSH of 10, I don't know why you wouldn't treat that person. But again, some pediatricians think it's not necessary. I personally would treat that person. When I say pediatricians, I mean pediatric endocrinologists in the United States. Yeah.
Thank you, Dr. Cooper. That's it from our side. Thank you for sharing your thoughts with us. Thank you.
Thank you, Dr. Anna. Thanks again for your attention.